Let me tell you about a Tuesday night that I still think about. A man walked into my emergency room, not rushed in, not carried in, walked in, holding a paper cup of coffee in one hand and his car keys in the other. 58 years old. He apologized to me before he even sat down. He said, "Doc, I feel silly being here. It's probably just something I ate." And he had this look on his face, that look I've seen 1,000 times over 17 years of medicine, where a grown man is embarrassed to take up space, embarrassed to be the guy who made a fuss over nothing. 40 minutes later, that same man was in the cardiac unit having a blocked artery opened up. And here's the part I want you to sit with. If he had listened to that voice in his head, the one telling him not to make a fuss, the one telling him it was probably the gas station burrito, he would not have made it to Wednesday. So the question I want to answer for you today is the exact question I ask myself every single shift. The question that stands between a scare and a tragedy. When chest pain walks through my door, how do I know? How do I actually know whether this is a heart attack or whether this is your body doing something dramatic but ultimately harmless? Because both of those things happen constantly. The vast majority of chest pain I see is not a heart attack. But the whole game, the entire skill of my job, is not missing the one that is. I'm Dr. Callum Everhart. Pull up a chair. Let's talk about this properly, because I promise you the way most people think about chest pain is almost completely backwards. And by the end of the next 20 minutes or so, you're going to understand your own chest better than you ever have. Now, the first thing I need to unteach you is the movie version. You know the one. A man clutches his left arm, grimaces, and drops to the floor. Dramatic, clean, obvious. And it does happen that way sometimes. But if that's the only picture you're holding in your head, that picture is going to get somebody killed. Because real heart attacks are often quiet, sneaky, and profoundly easy to explain away. The heart, it turns out, is a terrible communicator. It doesn't send you a clearly worded telegram. It sends you a vague, mumbled, easily ignored feeling, and it trusts you to take it seriously. So let me take you inside my head. When a person is sitting in front of me holding their chest, I'm not looking for one magic sign. I'm building a picture, the way you'd build a case, from a handful of specific questions. And you can ask yourself these same questions. That's the whole point of today. The first thing I want to know is what the pain actually feels like. And I mean the texture of it, the personality of it. This matters enormously. When someone describes their chest pain to me as sharp, stabbing, like a needle, like a knife point, something they can put one fingertip on precisely, I relax a little. I don't relax completely, but I relax a little. Because true heart pain, the pain of a heart that is starving for blood, is almost never sharp and pinpoint. It's the opposite. It's dull. It's heavy. People reach for words like pressure, squeezing, tightness, fullness. They'll say it feels like an elephant is sitting on their chest. They'll say it feels like a belt being cinched tighter and tighter. There's a famous thing we watch for. When a patient describes the pain, do they point with one finger, or do they put a closed fist against the center of their chest? That clenched fist, held right over the breastbone, is something we take very seriously, because it's the universal, wordless language of a heart in trouble. Sharp and pointy tends to be muscle or nerve or lining. Heavy and vague and central tends to be the thing that scares me. The second question is, where does it live and where does it travel? Chest pain that stays in one tiny spot, that you can isolate, that moves when you poke it, that's a different animal than pain that sits in the whole center of your chest like a weight and then starts to spread. And spread is the word I'm listening for. Heart pain radiates. It creeps into the left arm, yes, but that's not the only route. It goes up into the jaw. It settles into the neck. It wraps around into the back, between the shoulder blades. It goes down into the pit of the stomach and pretends to be indigestion. I have had patients absolutely convinced they had a bad tooth, or a pulled muscle in their shoulder, or heartburn that wouldn't quit, and the real story was their heart. So when someone tells me the discomfort in their chest is also making their jaw ache, or their arm feel dead and tingly, my attention sharpens like a knife. Let me pause here, because this next point is one of the most important things I will say all day, and I need you wide awake for it. For decades, the entire description of a heart attack was written by studying men. The crushing central chest pain, the left arm, all of it. That's the classic male presentation, and it's real. But women very often have heart attacks that look nothing like that. A woman's heart attack can show up as overwhelming, bone-deep fatigue that came out of nowhere. It can show up as shortness of breath with no chest pain at all, as nausea, as a cold sweat, as pain in the upper back or the jaw, as a vague sense that something is deeply, unshakably wrong. And because it doesn't match the movie, women wait longer to come in. And, I'm going to be honest with you, they have historically been taken less seriously when they arrive. If you are a woman watching this, or you love one, I need you to hear me. Your heart attack has permission to look different. And that difference has killed too many people who were told it was just stress or just anxiety. Trust the sense that something is wrong. Now, while we're here, do me a favor. If you've ever brushed off a symptom because it didn't look like the movie version, or if you know someone who did, drop a comment below and tell me what it was. I read these, and I promise you the person scrolling past your story might recognize themselves in it. That comment could genuinely be the nudge that sends a stranger to get checked. So take a second and do that for me. All right. The third question I ask is my favorite, because it's the one that does the most work, and you can use it on yourself tonight. What brings it on, and what makes it change? This is the tell. This is the fingerprint. Here's what I mean. A heart that's short on blood supply has a very particular relationship with effort. Think about the mechanics for a second. When you climb a flight of stairs, or carry the groceries in, or walk uphill into a cold wind, your muscles demand more blood, so your heart has to work harder, so the heart muscle itself demands more blood. If one of the arteries feeding the heart is narrowed, it can't deliver. And that mismatch, demand going up, supply unable to follow, that's what produces the classic squeezing chest discomfort. So the golden pattern I'm hunting for is this: pain that comes on with exertion and eases with rest. Man walks to the mailbox, chest tightens, stops, waits a minute or two, it fades. Walks again, it comes back. That predictable, effort-linked, rest-relieved pattern, we call the stable version of that angina, and it is a genuine warning shot across your bow. It's your heart telling you, in its mumbling way, that a pipe is getting clogged. That person needs to see a doctor soon, even if the pain always goes away. But here's the flip side, and this is where you can reassure yourself a little. There are kinds of chest pain that change in ways a heart attack simply does not. If your pain gets sharply worse when you take a deep breath in, and eases when you breathe shallowly, that points me toward the lining of the lungs or the chest wall, not the heart, because your heart doesn't care how deeply you breathe. If your pain changes when you twist your torso, or reach across your body, or when you press on a specific spot on your ribs, and you can recreate the exact pain with your own thumb, that is muscle and joint and cartilage, and I can often reproduce it right there in the room, which is oddly one of the more reassuring findings in all of medicine. There's a condition where the cartilage joining your ribs to your breastbone gets inflamed, and it can produce genuinely frightening chest pain, pain that feels like the real thing, but you can press on it, and there it is. Your coronary arteries are buried deep inside your chest. You cannot press on them with your thumb. So pain you can push on and recreate is, more often than not, coming from the wall of the chest, not the engine inside it. Which brings us to the great imposter, the one that fools everybody, including me sometimes: acid reflux. Heartburn. The stomach and the heart are neighbors, sitting practically on top of each other behind the breastbone, and they share some of the same nerve wiring, which is a cruel joke of human anatomy. Reflux can produce a burning, gnawing pain right in the center of the chest that people are utterly certain is their heart. And sometimes, this is the maddening part, a heart attack produces something that feels exactly like indigestion. So how do I lean one way or the other? Reflux tends to arrive after meals, especially big fatty ones, especially lying down at night. And it often comes with a sour taste at the back of the throat, and it frequently settles when you take an antacid. Heart pain doesn't usually care whether you just ate, and it does not resolve because you chewed a chalky tablet. But, and please write this on your heart, I have admitted patients whose heartburn was a heart attack, and the antacid did nothing, and thank God they came in anyway. The stomach is a liar, and the heart hides behind it. That's why we don't gamble on this one. Let me give you the fourth question, and this one is about the whole body, not just the chest. What else is happening at the same time? Because a heart attack is rarely a solo act. The heart is a central organ, and when it's in crisis, the rest of the body knows. So I'm asking, are you sweating? And I don't mean a warm day glisten. I mean a sudden, drenching, cold, clammy sweat that soaks through a shirt for no reason. We have a fancy word for that, but forget the word. The plain truth is that a person who breaks into a cold sweat while their chest hurts has my full, undivided, drop-everything attention. Are you short of breath, gasping, unable to get a full lungful? Are you nauseated, maybe actually vomiting? Are you lightheaded, gray in the face, feeling like you might pass out? Is there this strange, hard to describe sense of impending doom? And I'm not being poetic, that specific feeling that something is terribly wrong sensation is a recognized and ominous symptom that we're trained to respect. When chest discomfort travels in a gang with sweating and breathlessness and nausea, that combination lights up every alarm I have, because that is the body-wide fingerprint of a heart in genuine trouble. Now I want to talk about the part nobody can feel, the part that's happening under the surface long before any pain shows up, because this is where you actually have power. Everything I've described, the pain, the sweat, the breathlessness, those are the fire alarm. But the wiring was overheating for years, so when someone lands in my emergency room, I'm not just reading their symptoms, I'm reading their risk. And their risk is a story written over decades. I'm thinking about age, because the odds do climb as the years add up, and there's no shame and no dodging that. I'm thinking about blood pressure, because pressure that's run high for years is like running your home's plumbing at too many pounds of force. Eventually it damages the pipes from the inside. I'm thinking about cholesterol, specifically the way certain fats in the blood build up into deposits inside the artery walls, narrowing them silently, painlessly for years, until one of those deposits cracks and a clot forms in seconds and slams the door shut. I'm thinking about diabetes and blood sugar, which is a quiet destroyer of blood vessels, and worse, can blunt the pain signals so that a diabetic can have a heart attack with strangely little chest pain at all. I'm thinking about smoking, which does damage on a level people still underestimate. And I'm thinking about family, because if your father or brother had heart trouble young, or your mother or sister did, that tells me your genetics dealt you a particular hand, and we should play it carefully. Here's why I'm telling you all this. Two people can walk in with the identical, vague chest ache. One is a lean, active person with perfect numbers and no family history. The other has high pressure, high cholesterol, smokes, and lost a father to a heart attack at 50. Same symptom, wildly different meaning. The exact same ache is a footnote in one person and a 5-alarm fire in the other, and the difference is the story underneath. So if you take one action from this whole video, let it be this. Know your numbers. Know your blood pressure. Know your cholesterol. Know your blood sugar. These are cheap, painless things to measure, and they turn you from someone guessing about their heart into someone who actually knows the terrain. Let me bring you back into the room with me now, because I want to show you what happens after all these questions, so the emergency room feels less like a mystery. When we genuinely suspect the heart, we move fast and we move in a particular order. The first thing, almost within minutes, is the heart tracing. That quick, painless test with the little stickers on your chest that draws a picture of your heart's electrical activity. Sometimes it screams the answer at us immediately, a specific pattern that tells us an artery is blocked right now and we need to open it right now. But, and this catches people off guard, a normal tracing does not clear you. It absolutely does not. A heart attack can be brewing with a tracing that looks reassuring, which is exactly why we don't send people home on that alone. So the second thing we do is draw blood and look for a specific marker. When heart muscle is being damaged, it leaks a particular protein into the bloodstream, and we can measure it. The catch is that it takes a little while to rise, which is why we often draw it once, wait a few hours, and draw it again to see if it's climbing. That waiting period is agonizing for patients. You feel fine, the first results looked okay, and you just want to go home. I understand that itch completely. But that wait is us being careful on purpose, watching to see whether the story changes. That's not us being slow. That's us refusing to miss the quiet ones. And I'll be straight with you about something, because trust matters more to me than looking infallible. There is no single, perfect test. There's no machine I can point at your chest that gives me a green light or a red light with total certainty in the first 10 minutes. My job is to weigh all of it, the character of the pain, the pattern, the associated symptoms, the risk story, the tracing, the blood work, and make the safest possible call. And when I'm genuinely unsure, I will always err toward keeping you and watching you. Because the cost of an unnecessary night in the hospital is an inconvenience, and the cost of sending home a heart attack is a life. That math is not close. It is never close. Now here's where I turn the whole thing around and put it in your hands. Because you are not going to be in my emergency room most days of your life. You're going to be at home, at work, on a walk, at a restaurant, and you're going to have to make the first call yourself. So let me give you the simplest, most honest guidance I have. If you have chest discomfort, pressure, tightness, heaviness, squeezing that lasts more than a few minutes or that goes away and comes back, especially if it comes with any of that gang of symptoms I mentioned, the shortness of breath, the cold sweat, the nausea, the pain spreading to your arm or jaw or back, the sense that something is deeply wrong, you do not investigate. You do not wait to see if it passes. You do not finish your meal or your meeting or your chores. You call emergency services. In the United States, that's 911. You call and you say the words chest pain because those two words move you to the front of the line. And I need to be very firm about one more thing because it kills people every single year and it is entirely preventable. Do not drive yourself to the hospital. I know the instinct, you feel okay-ish. The emergency room is only 10 minutes away. Calling an ambulance feels dramatic and expensive and embarrassing. But if your heart's rhythm goes haywire on the road, you are now a moving danger to yourself and everyone around you. And you've lost the single most valuable thing an ambulance gives you, which is that the treatment starts the moment they reach your door. Those paramedics can run the heart tracing in your living room. They can give you medication on the way. They can radio ahead so the whole team is waiting for you. When you drive yourself, all of that starts only after you park and walk in. Let them come to you. That is not weakness. That is you being smart under pressure. And one small powerful thing about aspirin, because people ask me this constantly, if you truly suspect a heart attack and you're waiting for help, chewing a regular aspirin, chewing it, not swallowing it whole, because chewing gets it working faster, can help because it thins the blood a little and can slow a forming clot. But, and this is important, only if you're not allergic and have no reason you've been told not to take it. And this never, ever replaces calling for help. It's something you might do while the ambulance is on its way, not instead of the ambulance. When the emergency dispatcher is on the line, ask them and do what they tell you. I want to close by going back to that man with the coffee cup and the car keys, the one who apologized to me for being there. Because I think about how close he came to trusting the wrong voice, the polite voice, the don't make a fuss voice, the it's probably nothing voice that so many of us, especially the men watching this, who've been putting off that checkup for years, have running in our heads on a loop. That voice sounds reasonable. It sounds mature and stoic and considerate. And every so often, it is dead wrong in the most literal sense of the phrase. So here's what I want you to walk away holding. Most chest pain is not a heart attack. That's true. And I don't want you living in fear of your own chest, jumping at every twinge. But you are not equipped, and frankly, neither am I from across a room, to tell the difference with total certainty in the moment. And that's precisely why the rule is so simple. When it's the heart, minutes are muscle. Every minute an artery stays blocked, a piece of your heart is dying and does not grow back. So we don't gamble with those minutes. We would rather have you sheepishly apologize to me for a false alarm, and I have that conversation happily, all the time. And I mean it when I tell those patients they did exactly the right thing, than have you be brave and silent at home while the clock runs out. You know your body. You know when something is off in a way you can't quite explain. Honor that. The bravest, smartest, most loving thing you can do, for yourself and for the people who need you around, is to make the fuss. Be the person who came in for nothing. I will take 1,000 of those over one who waited. If this helped you understand your own heart a little better, do the people you love a favor and send it to them. The stubborn husband, the mother who downplays everything, the friend who's been meaning to get their numbers checked for 2 years. And tell me down in the comments, what's one health thing you've been putting off? Naming it out loud is how it starts to change. Take care of that heart of yours. It's been beating for you without a single day off since before you were born. The least we can do is listen when it finally speaks up. I'm Dr. Everhart. I'll see you in the next one.